So thank you all for your attendance, and thank you doctors for the opportunity. So today I will be presenting hypertension and pregnancy according to the European Society of Cardiology Guidelines. So hypertensive disorders in pregnancy are the most common medical complications affecting 5 to 10% of pregnancies worldwide. Hypertension has a negative effect on the mother and the fetus. One of the most common maternal risks of hypertensive disorders are abruption, stroke, DIC, and multi-organ failure. And most common fetal risks are intrauterine growth retardation and up to 25% of cases of preeclampsia, prematurity, and death. Now, diagnosis of hypertension should be routinely done upon each regular antenatal visit with repeated blood pressure readings, preferably on 2 occasions more than 15 minutes apart. The patient should be in the sitting position, and the use of automated blood pressure measuring devices is not recommended, since they tend to underestimate blood pressure measurements during pregnancy. So till now, the gold standard for blood pressure measurement is the sphygmomanometer. And although ambulatory blood pressure measurement is superior to routine blood pressure measurement and is better in predicting outcomes, unfortunately, it's not routinely done. Now, in each pregnant patient presenting with hypertension, the basic tests that should be done are urinalysis, blood count, hematocrit, liver enzymes, creatinine, and serum uric acid, because hyperuricemia was found to be associated with increased maternal and fetal risks. Proteinuria assessment should be done in each pregnancy, early in pregnancy, to detect any pre-existing renal disease, and in the second half of pregnancy to search for preeclampsia. So a dipstick test of more than 1+ should warrant further investigations, such as ACR ratio, albumin-creatinine ratio, and an ACR cutoff of 30 can be used to identify proteinuria. So if we have an ACR ratio less than 30, proteinuria can be ruled out. However, if an ACR ratio is more than 30, here we have to do 24 urine hour collection of proteinuria. There is another risk assessment tool that can be done after 20 weeks of gestation, which is the Doppler ultrasound of the uterine artery. It can detect pregnant women who are at a higher risk of gestational hypertension, preeclampsia, and growth retardation. Now, hypertension in pregnancy is diagnosed whenever we have office or in-hospital blood pressure values of more than 140 and or diastolic blood pressure more or equal than 90. Mild hypertension is between 140 and 159 over 90, 109, and severe hypertension is blood pressure between 160 over and or diastolic blood pressure more or equal than 110. Now, we classify hypertension into 5 entities. We have what we call the pre-existing hypertension. It's when we have hypertension present before pregnancy or before 20 weeks of gestation, and it usually persists for more than 6 weeks postpartum. However, gestational hypertension is when we have the first diagnosis of blood pressure during pregnancy and after 20 weeks of gestation, and it usually resolves within 6 weeks postpartum. Preeclampsia, it is an entity of gestational hypertension associated with proteinuria. We have also what we call pre-existing hypertension plus superimposed gestational hypertension. And finally, we have the unclassified hypertension. It's when the first blood pressure reading was taken after 20 weeks of gestation. So reassessment after 6 weeks postpartum is helpful to distinguish between pre-existing and gestational hypertension. Now, preeclampsia syndrome, it is an entity of gestational plus proteinuria, significant proteinuria. It is a common cause of premature delivery due to placental insufficiency, and it should be assessed and suspected when we have de novo hypertension during pregnancy associated with either headache, visual disturbances, abdominal pain, and abnormal laboratory tests, as proteinuria may be a late manifestation of preeclampsia, and eclampsia it is a severe form of preeclampsia associated with seizures. Now, what are the risk factors of preeclampsia? Women who are at high risk of preeclampsia have any of the following: either CKD, chronic hypertension, diabetes, autoimmune disease, or hypertensive disease during a previous pregnancy. And women who are at moderate risk of preeclampsia have more than one of the following risk factors: first pregnancy, multiple pregnancy, family history of preeclampsia, BMI more than 35, and age 40 years or older, and pregnancy interval of more than 10 years. Now, can we prevent hypertension or preeclampsia? Currently, there are no sure way to prevent hypertension. However, women who are at high or moderate risk of preeclampsia should be advised to take aspirin 100 to 150 milligram per day from week 12 to week 36 and 37. And for pregnant women who have a low dietary intake of calcium, calcium supplementation here is recommended for prevention of preeclampsia of more than 1 gram per day. Now, how can we manage hypertension during pregnancy? Till now, the management of hypertension is challenging, and it requires collaboration between cardiologists and obstetrician. There is a limited role for non-pharmacological management during pregnancy for dietary and lifestyle interventions. However, pregnant women should continue regular exercise with caution, and obese women with a BMI more than 30 should be advised to avoid a weight gain of more than 6.8 kilograms. The use of antihypertensive drugs during pregnancy is essential to control blood pressure and to prevent complications. However, we should know that the drugs used should be safe for the fetus because it has an increased risk of congenital heart diseases. That's why the pregnancy and lactation labeling rule system must be checked before prescribing any drugs to a pregnant woman, and the target blood pressure for all hypertensive pregnant women should be less than 140/90. The blood pressure threshold to initiate antihypertensive medication in mild hypertension is more than 150/95 in women with pre-existing hypertension. However, the threshold will be lower in women with gestational hypertension, pre-existing hypertension superimposed with gestation, or hypertension associated with any organ damage or symptoms, and the threshold will be more than 140/90. Now, the drugs of choice for the management of mild hypertension are the main three classes: beta blockers, methyl-dopa, and calcium anti-CBs. Beta blockers are the first-line medication during pregnancy and lactation. We can use the non-selective beta antagonist such as labetalol, which is the commonly used drug, and we can use other beta-selective drugs such as metoprolol and bisoprolol. We should know that beta blockers may cause fetal bradycardia or intrauterine growth retardation, so that's why atenolol should be better avoided during pregnancy because it showed that it has been associated with increased risk of growth retardation. Alpha-methyl-dopa is one of the most and safest drugs used during pregnancy, and it has been used for more than 40 years. The recommended daily dose is 0.5 to 3 grams in 2 to 4 doses, and it has many side effects. And CCBs are also one of among the recommended drugs during pregnancy. We can use either dehydro or non-dehydropyridines, and the most available data is on nifedipine. Now, what about the use of diuretic during pregnancy? We should avoid diuretic during pregnancy because it has a potential risk of oligohydramnios unless there is a clear indication for diuretic use, such as in heart failure. And diuretics should be avoided also in preeclampsia because there is a high risk of volume depletion. And when it is indicated, only loop diuretics are allowed. And all renin-RAS system inhibitors should be are not recommended because they increase the risk of dysplasia, pulmonary hypoplasia, and growth restriction. Now, for the management of severe hypertension, usually all pregnant women with severe hypertension should be hospitalized, and IV antihypertensive drugs should be started. And according to the European Society of Cardiology, hypertensive emergency during pregnancy is defined as an systolic blood pressure more than 170 or diastolic more than 110, and immediate hospitalization and parenteral antihypertensive drugs should be used. We can use either IV labetalol or nicardipine, as well as oral nifedipine or methyl-dopa. Now, IV hydralazine and sodium nitroprusside are no longer the drug of choice, and IV sodium nitroprusside should be avoided because the prolonged treatment is associated with high risk of fetal cyanide poisoning. What is the treatment of preeclampsia and eclampsia syndrome? First of all, we should admit with administration of antihypertensives, IV labetalol, nicardipine, and we should also start IV magnesium sulfate. It is recommended to prevent preeclampsia and to treat seizures, but we should be cautious with the use of IV magnesium with CBCBs because there is a high risk of severe hypotension due to synergism, and the drug of choice in case we have preeclampsia associated with pulmonary edema is IV nitroglycerin. And as my colleague said, delivery of the placenta is the only cure of preeclampsia, and vaginal delivery is preferred unless there is any obstetric or medical contraindication. So delivery is indicated in asymptomatic pregnant women at 37 weeks or in preeclampsia associated with either visual or hemostatic disorders. Now, what is the prognosis after pregnancy? There is an entity called blood pressure postpartum. It is common in the first week of pregnancy. It may be physiological, or we may have a late onset of preeclampsia. Here, blood pressure should be monitored daily for the first 5 days post-op. Okay, 1, 2. Methyl-DAPA is still the drug of choice. However, it should be used with caution in women at risk of postpartum depression, because methyl-DAPA, it showed that it increases the risk of postpartum depression. In lactating women, all antihypertensive drugs can be taken because they are excreted into breast milk. Most of drugs are present at very low concentration, except for propranolol and nifedipine. So beta blockers and CCB, these class are safe for lactating women, and the most available data on safety was on labetalol and metoprolol, and for CCBs it was on felodipine and nifedipine. And here, for lactating women, ACE inhibitor can be used unless the neonate is premature or it has any renal failure, and enalapril is the most widely used. There is a risk of recurrence in subsequent pregnancy, and the earlier the onset of hypertension in the first pregnancy, the higher the risk of recurrence in a subsequent pregnancy. And all women who develop hypertension during pregnancy are at higher risk of hypertension, stroke, or ischemic heart diseases in later adulthood. So lifestyle modification and annual visits are needed. And here are the recommendations according to the guidelines, and thank you.